Versed, you're looking at 5 to 15 minutes, okay? Duration. Think of it this way. We usually dose drugs in accordance with their usual duration. When you're giving repeated doses of Ativan, okay, not in an acute situation, but with a patient that's in the ICU, what's the usual interval? It's 4 to 6 hours, right? So the duration of the drug is 4 to 6 hours. Okay. What about Versed? It's less than 60 minutes. All right? Side effects. Well, neither of these drugs has any bad side effects other than the general respiratory depression. Okay? Now, Versed has a side effect that we usually like. All right? It is an amnestic agent, meaning you give the drug. If it works out well and the dose is enough, the patient is not experiencing undue stimulation. Many times they will forget what has happened during that interval. All right? They will remember up until that time, but once the Versed really starts taking effect, they're essentially going to not be able to remember things. Again, it's based on what kind of stimulation the patient is experiencing, how much Versed did they get repeated doses, et cetera, et cetera. There are people who can remember the things the procedures, et cetera, that they have experienced, but many times they can't. And so that's one of the side effects that we actually use for our advantage, all right? Dose range. Again, the usual dose, and obviously on all these drugs I'm talking IV, as that's how we usually administer them. It's 0.1 milligrams per kilogram. Okay, same thing applies. If you're worried about the patient, you don't have an established airway, they are a little agitated, but you're concerned that we may push them over the edge, then you can use half of that dose, all right? You can always give more medication. It is quite a bit more difficult to take it back once it's administered, all right? Versed, there are many routes to give Versed, and the dose differs, all right? You can give it intranasal, you can give it PO, you can give it IV or IM. All right, most of the time we're talking about IV, okay? So once again, it's half to, or 0.05 to 0.1 mg per kg. And, same thing applies. If you're worried about pushing the patient into respiratory depression, then, start with a low dose and go up from there, okay? All right, so that's Versed and Ativan. Now, one drug that I want to talk about, knowing that you guys do not carry it, that it's not something in general that non-physicians use, I do think that it's a wonderful drug if you are assisting with procedures, if you're assisting with trauma patients or whatever. The chances that someone is using propofol is fairly high, and so as the general airway and emergency response team, no matter whether it's within the hospital or without, I think it's a drug that it would behoove you to know about, right? And I can't spell. That's really bad. Propofol, all right? Propofol is truly classified as an anesthetic agent, all right? If everything, well, most things in medicine are on a continuum, right? Here we have conscious sedation, okay? And on this end of the spectrum, we have anesthesia, all right? What we usually want for our patients is somewhere in between, okay? That's usually our goal. The difference between conscious sedation and anesthesia, or getting an anesthetic effect, is that you lose your ability to protect your airway, all right, if you are given a proper dose of an anesthetic agent. That is why nurses are not allowed, or medical students, or a resident, or even an MD who is not trained in airway management, all right, that is why they are not allowed to use propofol. Propofol is an anesthetic agent. If you give a significant dose, your patient will not be able to protect their airway, okay? Now, the onset of action is, probably about 30 seconds, all right? The peak effect, it depends on the titration, all right? The thing about propofol is its metabolism is rapid. All right, I don't know what's going on. There we go. So if you don't give it as a continuous infusion, it will wear off in just a matter of a couple of minutes, okay? The duration, again, it's a titration, okay? Side effects, just as we talked. Respiratory, not only respiratory depression, but absolute apnea and loss of your airway mechanisms, okay? Not a drug to be taken lightly. Dose range. Once again, it's a titration, okay? It's difficult to really assess a specific dose. It's usually administered to effect. You use the least amount of drug to get the effect that you want, okay? So the dosing is a little off in that regard, unless you're talking about a prolonged infusion, okay? So that is propofol. Once again, a wonderful, wonderful drug if it is used correctly and the proper things are in place for its use, all right? Now let's get to the paralytics, okay? All right, I told you that I think it would behoove you to review SUX, and because it's a very historical agent, was used with almost exclusively for many, many years, but because we have better agents now, it's probably not the agent of choice, particularly for children. All right, so we'll first do the first two that we use most often, and that's vecuronium and rocuronium, okay? And we'll just kind of do a little comparison. Now, once again, why is it important to know the onset of your paralytic? Well, wouldn't it be nice to know exactly how long you're going to have to assist the patient with ventilation before you can actually intubate your patient, all right? So you need to know this, all right? It's not just fluff. Onset for VEC is 60 to 90 seconds, okay? Onset for rocuronium, if you give the proper dose, all right, it's shorter, 30 to 60 seconds. Peak effect for VEC, you're basically usually paralyzed. Paralytic agents are different than other agents because of the way they work, the purpose for them, whatever. It's not so much a peak and a wear off, okay? You can be partially paralyzed, but you're getting into semantics there. So